Okay, I think I'll get started on this webinar as far as just some housekeeping and answer a few questions before I actually get started with the content. Those of you who have not attended my webinars before, I'll introduce myself. My name is Dr. David Kunashko. I'm a chiropractor. I've been practicing for over 30 years now, and I've been involved with laser therapy, or of course we know it's now known as photobiomodulation, for over a decade in the capacity as a practitioner and also an educator. I've presented all over the world at different conferences and involved, of course, with Meditech and Bioflex as the medical director. My background before a chiropractor was in molecular biology and molecular genetics at University of Toronto. So I'm really quite fascinated as to the mechanisms of how photobiomodulation works and specifically how it can help patients. It's a very unique kind of therapy. There's lots of good science behind it and some pretty bad science behind it, and an awful lot of bad marketing behind it. And that's where everything gets confused. And unfortunately, where a lot of people come in, they read things and they're misinformed, to say it bluntly, maybe, and they don't really understand what it is this can do, or the potential for it, and some of the things around it. So with these webinars, I try to use good facts and science. Today's webinar is on Chondromalacia Patellae. What I try to do with these webinars is I give you a fairly good in-depth view of the anatomy, pathophysiology, epidemiology, etiology of the condition, because of course, these webinars are designed for healthcare professionals. Anyone can listen in, that's fine. But I have another stream of webinars more for the general public. These ones are more designed for healthcare professionals. And then I, of course, talk a bit about how photobiomodulation can help the condition. I don't go into a lot of depth with that because I do talk a lot about this in other webinars. And then I'll specifically talk about if you have our equipment, how you would approach treating this particular condition in maybe a little bit different way than you might be used to treating, say, the knee joint, for example. That's my goal with you guys today. I appreciate you joining in today to listen in. The webinars are always recorded. So in future, if you want to join in a webinar and you're busy or you can't, just register, and the webinar, once recorded, it's edited, and then we send out an email with a link to watch it again if you so wish. Okay, so I see I have a few questions. I'd appreciate the questions to be typed into the Q&A box, not the chat function. There's a question from David Jones with respect to PRP and stem cell injections. I'll try and get to that at the end of the webinar. The answer is yes, and I do have some information about PRP, which, by the way, might be an option for Chondromalacia Patellae, but I'll try and address that at the end of the webinar as well, too. Okay, so let's get started. As I mentioned, what I'm going to cover, I think I've already mentioned that. I always have time for Q&A at the end as well, too. So some review of anatomy. We've all been there, done that, but maybe we haven't been there, done that for a long time. So let's just take a look about the anatomy. You would think it's a pretty simple anatomy. Hey, it's just a little sesamoid bone, but man, it's super complex. And every time I do these reviews, I go back, wow, like, this is a lot of stuff. So we know, of course, the patella is a sesamoid bone. It's the largest one in the human body. And it functions, of course, to protect the knee joint, but also, very importantly, it lengthens the lever arm of the quadriceps femoris, which then increases the area of contact between the patellar ligament and the femur. So basically, it allows to increase the force to be able to function at the knee joint. So if you look at the anatomy, and what's really interesting here is when you look at the articulating surfaces, especially the underside of the patella, you can see that there's different facets. Actually, depending where you look, there's up to 10, 12 different articulating facets. Most of the time, they just mention a medial, lateral, and an odd facet, but it's actually oftentimes broken down to more facets. But what's most important to understand for Chondromalacia Patellae is that the articulating surfaces on the underside of the patella is where the issue is, oftentimes more on the lateral side and the medial side, but that's really where you're trying to target light if possible to get into that area to help with the condition. Okay, so that's the articulating surface of the patella, and of course the patellar surface has, and the femoral condyle has hyaline cartilage as well. This is just another nice little view and to get a three-dimensional understanding of the patella. It's really important when you're using laser therapy is that you can visualize and understand your surface anatomy and where things are. Because when you use a laser probe, for example, even though the light is no longer, and by the way, many people don't understand this, but when laser light hits skin, it's no longer a laser coherent beam, right? So it actually starts to bounce around, reflect, absorb, scatter. So a laser beam, coherency is lost as soon as it hits the skin, but it's still super intense, deep to where you're treating, which means that you can really use it as a pinpoint kind of tool to get light into a specific area. And which is great when you're trying to treat something like this, where you're trying to target the area, but you also need to know exactly where you're pointing that laser probe and to ensure that you're targeting where you want to target. I'll talk a little bit about that as we progress. So the primary function of the patella, of course, is during knee extension, and this increases the angle with which the quadriceps tendon pulls on the shaft of the patella, kind of like a lever and a fulcrum, if you can picture that, like I've shown you on the far right. It also functions to allow smooth movement of knee inflection and extension, and of course, it protects the anterior surface of the knee joint. Now, let's take a look at the stabilizing aspects of the patella, because this is where chondromalacia patellae, and in fact anterior knee pain or patellofemoral syndrome, like there's probably 15 names for anterior knee pain, and I'm going to talk a bit about the confusion with that as well. I mean, today's topic is chondromalacia patellae, but you can kind of lump in a few other things in there as well, but the actual pathophysiological condition of chondromalacia patellae is very unique, right? So on the medial aspect, so we're looking here at the medial aspect in yellow, there's the medial patellofemoral ligament. This is what gives the most support on the medial side, about 60% of the support. Then there's smaller ligaments at play, like the medial patellomeniscal ligament, or the MPML in green. You can see it coming up from the medial meniscus up into the lower margin, medial margin of the patella, and then the medial patellotibial ligament. Of course, we know that ligaments are named according to the bony structures they attach, and you can see that's in the kind of the pinkish hue at the medial tibial plateau going up into the patella. So that's on the medial side. Now, the medial structures aren't nearly as strong as the lateral structures support-wise, and really in part that's mainly because of the iliotibial band, as well as other structures like the lateral patellofemoral ligament, which is shown in the yellow, and the lateral retinaculum, which is shown in the pinkish hue, and the joint capsule, which I didn't put in here, but we know, of course, a joint capsule surrounds the entire joint, anterior, posterior, and medial and lateral aspects of the joint itself. So if you're looking at the structures that support the patella, the lateral structures are actually much stronger than the medial structures. So the iliotibial band, which is very problematic in something like chondromalacia patellae, if it's under excessive tension, it can cause excessive lateral tracking and or causing tilting of the patella. And this is where you start to get issues that can lead to something like chondromalacia patellae. The other issue can be a tensor fasciae lata being tight as well. Remember, the ITB itself is a non-contractile structure. So a lot of ways you're going to treat chondromalacia patellae, of course, is rehab, which will be strengthening and stretching and those kinds of things. And they all come into play, and they're really critical, as well as looking at the anatomy, good gait analysis, and all these other things, which you all know about. But before that all happens, you need to address inflammation, and you need to address a deterioration of cartilage. And that's where photobiomodulation is so unlike anything else. And in fact, you can't achieve that with exercises and rehab. The other thing that's really important for treating chondromalacia patella is understanding the blood supply. And I say that again because blood supply, you would think, well, what's the deal with blood supply? Well, first of all, hyaline cartilage doesn't have direct blood supply. It gets it indirectly, right? If we're trying to heal cartilage, we want to improve the nutrition of the synovial fluid and the supplies and the nutrients that go into the fluid to allow that hyaline cartilage to repair itself. And that is done indirectly through the blood. Now, a large portion of the blood supply excuse me, that supplies patella originates from the popliteal artery. The superior lateral, medial, infralateral, medial, descending and anterior genicular arteries, all branches of the popliteal artery, of course, originating from the posterior aspect of the knee. So it may seem funny that we'd want to treat the popliteal region of the knee if we're treating something like patellofemoral syndrome or chondromalacia patella, and that's because we're trying to treat the blood supply. When you treat the blood supply, you're going to, in fact, promote increased stem cells, increased activity of macrophages and neutrophils, and reduce inflammatory exudate as well. So the more blood you can treat, and that supply the area that you're after, the better result you'll get as well. This particular webinar, there's a lot of verbiage. It was hard for me to cut back on it, but there's just so much information. So again, when we're looking at the articulating surfaces of the patella, it's the superior 2/3 of the posterior articular surface of the patella that articulates with the anterior surface of the femoral condyles. There's a lot of contact there with the underside of that patella. Okay, now the medial femoral condyle is actually larger than the lateral femoral condyle. Yet it's the lateral portion that's more problematic. The thing that's really interesting is that the articular cartilage of the patella is really thick. And in some areas, it's measured to be up to 7 millimeters of thickness. And that's because, of course, of the huge amount of stress that occurs when you're contracting your quads and doing exercises like running or jumping or what have you. And we know that chondromalacia patella is really super common in young athletes, especially females, because of the increased stress. And over time, it becomes a wear and tear issue and hyaline cartilage degradation. Okay, so that's really the target of what you're trying to achieve. And hopefully you get at it before there's extensive deterioration, because once it's really extensive, then it becomes a lot more difficult to improve. If you look at the anatomy in an extended knee, you can see here how it sits nice and straight in the groove of at the bottom of the femur. Of course, when you bend your knee, then the patella tracks along the groove inside the femur. Okay, let's talk a bit about chondromalacia patella now. So it comes from the Greek words chondros, which is cartilage, and malakia, or which is softening in Greek. So that's the origin of the actual word itself. And there's lots of terms for chondromalacia patella. Sometimes you'll see it called patellofemoral syndrome, runner's knee, jumper's knee, anterior knee pain. The actual pathophysiology way to describe it is chondromalacia patella. And that's really only diagnosed through specific radiographic means or MRI or arthroscopic observation. There are tests, orthopedic tests we all know, like Clark's sign and compression test, and I won't go over all those things. That's important to get a good understanding of probably what's going on, but you won't be able to actually grade it unless you have an MRI or other radiological technique to do that. So typically, chondromalacia patella is an overuse syndrome. So it's most common, as I mentioned, in young athletes, especially females, and I'll talk about that very shortly. Sometimes you come across the term patellofemoral pain. So this is a little bit different than chondromalacia patella. Basically, it's anything other than chondromalacia patella in the anterior portion of the patella, pain-wise. So it is a diagnosis, but it's sometimes is lumped in there with chondromalacia patella, but it's not the same pathophysiology. There's different reasons. It's more of an overuse kind of scenario, muscle imbalance, those kinds of things. But when you get degradation of the cartilage, that's where you get the diagnosis of chondromalacia patella. Both CMP and PMP occurs, as I mentioned, more commonly in females than males. I say it's about a 2/3 to 1/3 ratio. And 70% of all patients that have patellofemoral pain is in the younger age group of 16 to 25. And some of the stats I read is that 1 in 4 young people will actually develop chondromalacia patella, especially if they're active. So it's a really common problem. And patients that present with patellar pain over the age of 50, that's oftentimes a result of osteoarthritis developing in the patella itself. Chondromalacia patella is often associated with patellar tracking. And this is because it starts to track towards the lateral side of the femur, and this will cause increased friction of the patellar and femoral articular cartilage. This is an important point to understand because when you're using a laser probe to treat that area, you want to focus a little bit more time on the lateral aspect than on the medial aspect. And of course, this will end up causing chronic inflammation and pain. Some of the main reasons for developing chondromalacia patella really revolves around patellar malalignment, and this can be caused by abnormal Q angle. In men, it's 14 degrees, and women, it's higher, 17, because of the wider hips, right? So because of that wider Q angle, this can increase the resultant lateral pull on the patella, and that's of course why we see a higher predominance in females. It can also be caused in part by muscular tightness of different muscle groups, including the rectus femoris, tensor fasciae lata, and the hamstrings. So these are all muscles that need to be tested and treated appropriately during the rehab portion of your patient treatment plan. Oh, and of course, the gastrocnemius as well. So other reasons for patellar malalignment, you have to look at the feet. Oftentimes there's excessive pronation as well. So that's something that should always need to be addressed for sure. Sorry about that, just a little cough. Things like a patella alta or patella baja, which is high riding, a low riding patella, can also be problematic. So sometimes the patellar tendon is shortened, and this causes a higher positioning of the patella. It's patella alta, or the opposite, where it's lengthened, can also cause abnormal mechanics of the patella. Of course, we all know about the vastus medialis, obliquus, and VM insufficiency. So that's something that always needs to be addressed and tested for properly for patients with chondromalacia patella. Again, as I mentioned earlier, you basically need our arthroscopic findings or MRI to really understand the extent of the depth of cartilage thinning or even subchondral bone changes. So when you get to an MRI, it's probably tough to see mild changes. It's going to pick up more moderate to severe stages, whereas if they go with a scope, then they can actually visualize and see a little bit more easily. But of course, it's invasive, so not typically usually done in the mild stages. If you look at diagnosing it according to the degradation of the cartilage, you're looking at stage 1, which is a softening and swelling of the articular cartilage. This is the best case prognosis. And so that while there's some damage, it's not quite severe. As you get to stage 2, then there's something called blister formation in the articular cartilage due to separation of the superficial from the deep cartilaginous layers. So now there's a lot more ongoing friction of the cartilage layers. There can be even fissures that are occurring over a fair portion of the articular cartilage. It can even extend to the subchondral bone. And then as we're getting to the moderate to severe stages, you're looking at more fissures and ulcerations, fragmentations, fibrillation of the cartilage that can extend all the way to the subchondral bone. But overall, less than 50% of the bone of the articulating surface is affected. But now once the later stages and you have over 50%, this is pretty severe ongoing chronic chondromalacia patella. You can even get osteophyte formation, and this is the worst case scenario. What's really interesting, as we probably all know, is our articular cartilage doesn't have direct nerve endings, so it doesn't cause pain. What causes pain are the structures around the patella, the synovial lining, the inflammatory exudate coming around that area that causes the pain and the redness associated with this condition. So let's talk a little bit about treatment. Now, I'm not going to go into a lot of depth about all the other things that you should be doing, because that's not the extent why I'm doing this webinar, but it's important to understand that unlike the cartilage damage due to, say, arthritis, damage caused by chondromalacia patellae, especially in young folks, it can often heal. So there's actually a really good prognosis if you address everything, including ways of healing this, the damage to the chondrocytes. So conservative treatment is obviously what you want to start off with, and it should be focused on decreasing inflammation and repairing cartilage. In preparation for this webinar, I was reading some papers that they talked about a lot of anti-inflammatories decrease the ability of chondrocytes to grow. So they actually say that anti-inflammatory meds aren't a good option or shouldn't be prescribed, because it actually slows down the repair rate of chondrocytes. So I think a lot of us that do listen in aren't prescribing these for our patients anyhow, but it just makes sense that there's probably other ways of helping manage your patient without reverting to ibuprofens and non-steroidal anti-inflammatories. Although, of course, if you're a medical doctor, that's going to be your main thing. But I disagree with that approach. So once the inflammation has subsided, then of course you're looking at physical therapy, and that's basically looking at strengthening the muscles involved, flexibility of the quads and the hams, looking at addressing any mechanical issues that you found. And these are all things that you need to really make sure are properly addressed, because if you have an athlete that's a runner or basketball player or whatever it is, and you know, they're going to be using their muscles a lot, then you have to make sure their mechanics are good. So remember that hyaline cartilage is composed, of course, of chondrocytes that are dispersed throughout an extracellular matrix. Now, this matrix consists of type 2 collagen, protoglycans, and water. The chondrocytes produce protoglycans, which are then secreted into extracellular matrix. Recall earlier that I said hyaline cartilage is avascular, as well as doesn't have a direct nerve supply as well. So nutrients diffuse directly from the synovial fluid. Photobiomodulation therapy is known to increase the repair and regeneration of cartilage via increasing the metabolism of chondrocytes that are stressed due to inflammation. And if you not quite sure what I mean by that, I probably have 50 webinars that I've done on how photobiomodulation interacts with the metabolism of cells that are undergoing metabolic stress. This is the key mechanism of how it works, but you need to get light to those cells directly to affect the chondrocyte directly. You can also, of course, treat the blood in the surrounding area, which helps to reduce inflammation indirectly. But if you want to have a direct effect on the chondrocytes, you need to get light as close as possible, or certainly so that the light can be absorbed into the chondrocytes. So photobiomodulation really should be the first line of treatment before the patient undergoes strengthening and rehab. The reason for that is you want to get the inflammation down. You want to get the repair going, and then you want to start to address those other things, because if you don't do it in that sequence, then you risk aggravating and not allowing the tissues to heal as effectively than if you stress them too much, right? So one of the first things you want to do when you're treating chondromalacia patella is treat the back of the knee, the popliteal region. And that's because you can have a profound effect on immunomodulating the blood supply that supplies the patella and helps to reduce inflammation. So you do want to do a popliteal placement of the array positioned something like this. This array emits red and infrared. And so the idea here is that it's going to be on for about maybe 12, 13, 14 minutes around there. I think it's around 12 minutes in total, red and infrared. And that really helps provide a pretty strong systemic or remote effect on the blood. And of course, is relatively close to the kneecap. So you should get a fairly good immunomodulating effect. You will not achieve this effect if you're just using a laser probe or a laser shower head or a class 4 and scanning it quickly over an area. You're just not going to achieve that effect. And if you choose to disagree, then we disagree. Then you want to treat the anterior aspect of the patella, obviously, right? And what I'm going to suggest is you do 2 placements anteriorly. One that's shifted a little bit to the medial, and one that's shifted a little bit to the lateral. And that's to affect as much of the patella that you can get on the medial and lateral aspects of the involved area. I suppose you could just do 1 placement over the patella, but I kind of like this position because you do get some extra exposure over the area, and more often than not, inflammation kind of spreads around the area. So it's kind of good to treat the entire anterior medial and anterior lateral aspect of the knee joint itself. So again, you're looking at 3 placements in total: popliteal, and then anteromedial, anterolateral, and position the array so that it covers. This doesn't really show you a great picture of it, but you want to make sure it covers the entire patella so that you get as much of the margins covered as possible. Now, once you've done that, so that should be about maybe 20, 30 minutes treatment time, or I guess, yeah, 30 minutes or so, 30, 40 minutes of treatment time. And then you're going to use a laser probe. If you have a red probe, you can use that as well. The infrared is what's going to penetrate into that cartilage as best as you can. Near infrared wavelengths between, I'm going to say, 780 to 840, 850 nanometers, and they say 810 to 840 is the deepest penetrating that you can get, but it will still suffice. And what you want to try and do is you want to treat the undersurfaces of the patella, both the medial and the lateral aspect. And it's really important here is that you probably want to have the knee, even though it's in a flex position, you probably want to have the knee in a more of an extended position, and you can gently push the patella from side to side. So if you're treating the lateral aspect of the patella, you can gently push in from the medial aspect out to the lateral aspect so it edges out a little bit, if you can picture that, and then gently apply the laser probe underneath the patellar surface. You're going to hold it nice and gently under the undersurface of the patella for at least 10 seconds, maybe 15 seconds per point before you move it to the next point. Of course, if it's a really acute scenario, you have to be very careful how you do this. But I think if you do it gently, there shouldn't be any major issues with doing that. Remember, of course, you have lots of other structures in the way: the joint capsule, patellar tendon, quadriceps tendon, patellar ligament. So when you're over the patellar tendon or the quadriceps tendon, you're going to have to treat for longer. So maybe hold it for 15 or 20 seconds because the light has to try and penetrate through the tendon or the ligament to get to the cartilage surface itself. And you may want to play around with the time that you hold the probe for as well. So maybe start at 10 seconds and maybe you work your way up because depending on the size of your patient and other kinds of things going on, you might need to hold a little bit longer, but start at around 10 seconds and work your way up from there. I know you guys have questions. I definitely get to those at the end. So the protocol itself, we use the standardized knee protocol that comes with the software, with the BioFlex software. The software is divided into 3 stages, stage 1, 2, and 3, which is increasing stimulation, including dosaging and pulsing of light. Stage 1 is really good for the acute entry level. Treat in an acute stage 3, 4, 5 days in a row if possible, and then you can probably go to 3 times a week once it's calmed down. Remember, to calm down this inflammation that's taken quite a while to develop will take some time. It might take several weeks to really start to calm the inflammation down. And it's going to take even longer that to repair and regenerate cartilage as well. So understand that this will take some time to occur. And during this time, you can have the patient doing some rehab. I mean, swimming, some other things are really good, but you certainly don't want to have them doing excessive strengthening exercises or other dynamic exercises that will stress the patella at this point. So the patient and the athlete typically has to be working with you and understand what you're trying to do. If they're trying to return too soon, it will redevelop and become more problematic as time goes on. You want to adjust the duty cycle and the frequency of the protocols. Usually you're going to increase those as the patient plateaus or they develop, how should I say it, they just sort of get used to a certain modulation, and you have to sort of change that as well. I'm not using the right terminology, but you want to see how they adapt to your treatment and then increase the stimulation. Okay, so I will get your questions next. I just want to mention a few things. I do have a few webinars coming up. They're all on our website. I have one for the personal therapy system for the general public on how laser therapy reduces inflammation. Then I have some facts and fictions about wavelengths and laser therapy. That should be a fun one. One about hair loss and one about post-workout relief using laser therapy as well. And we have an advanced certification training coming up in April with a guest speaker of Dr. Ben Ewan, myself, and Slava Kim, specifically about nerve healing, peripheral nerve healing, neuropathies, those kinds of things. I believe, well, I know I'm doing one on carpal tunnel syndrome. Slava's doing a presentation, and Dr. Ben Ewan's doing one on neuropathies. I think Slava's doing trigeminal neuralgia. And if you're new to laser therapy in general, once a month, I do something called Light Up Your Practice, which is designed for practitioners so that you can understand a little bit about the concepts of photobiomodulation, the mechanism of action, all those kinds of things, and talk a little bit about BioFlex and what we offer as well. It's a 3-hour free event, or free or close to free. I'm not sure, actually. But if you're interested, the next one is on March the 5th, and I believe it's at 9 a.m.